1, 2, 3, oh!
My baby don't walk around because her acetabulum is all displayed. And all the orthos know that ortholonic make me she's got CDA. No thanks to mom and dad, the ligamentous laxity has come her way. Dysplasia.
DDH is a disorder of abnormal development resulting in dysplasia and possible subluxation or dislocation of the hip secondary to capsular laxity and mechanical factors. The following four conditions lie within the spectrum of DDH. The final common pathway in DDH is increased laxity of the joint, which fails to maintain a stable femoroacetabular articulation. The increased laxity is most likely the result of a combination of factors. Any condition that leads to a tighter interuterine space, and consequently less room for the normal fetal motion, may be associated with DDH. These conditions include oligohydramnios, large birth weight, and a first pregnancy. It is important to note that the epidemiological data points towards hip instability as being the more prevalent issue rather than actual hip dislocation. The pathophysiology rests on the initial instability of the hip, which was previously discussed. This instability leads to abnormal morphology and development of the acetabulum, which can ultimately lead to a gradual dislocation. DDH in the neonate is often asymptomatic. The Barlow and Ortolani tests are therefore used as simple screens. The Galeazzi sign is best used for highlighting any leg length discrepancies. The walking child often presents to the physician after the family has noticed a limp, a waddling gait, or a leg length discrepancy. The affected side appears shorter than the normal extremity, and the child toe walks on the affected side. The Trendelenburg sign is positive in these children, and an abductor lurch is observed when the child walks. Radiographs are only useful when the proximal femoral epiphysis has ossified, usually by 4 to 6 months of age. Before this, ultrasound is a primary imaging modality. Radiographic measurements are useful in evaluating developmental dysplasia of the hip. Details of these measurements have been omitted for simplicity's sake, but one is encouraged to read further on these radiographic parameters. The goals in the management of DDH are to obtain and maintain a concentric reduction of the femoral head. Newborn hips that are Barlow or Ortolani positive should be placed in a Pavlik harness as soon as the diagnosis is made. Note that the Pavlik harness is contraindicated in the teratologic hip. Children between 6 months and 2 years, closed reductions are performed. The reduction is maintained in a well-molded spica cast. Failure to obtain a stable hip with a closed reduction indicates the need for open reduction. Open reduction is usually performed in children older than 2 years.
Goes to my head, makes me forget that my knee is so sore. I need a cure.
Avascular necrosis is the result of ischemic bone death of the femoral head after compromise of its blood supply. AVN is bilateral in 40% to 80% of patients. It is common in relatively young patients, with the mean age at diagnosis being 38 years old. Although no cause is found in 20% of cases, trauma, alcohol consumption, as well as corticosteroid use are a few of the main risk factors. Here's an easy way to remember the most common causes of avascular necrosis. The pathophysiology of AVN is largely unknown, but the final common pathway is understood to be intravascular coagulation. If a fracture is the cause, it will bleed and thus have a tamponade effect on the femoral head, therefore compromising its blood supply. AVN may be asymptomatic and is occasionally discovered incidentally on radiographs. When a patient has increasingly painful hip, buttock, thigh, or knee pain and no history of recent trauma, AVN of the femoral head should be considered. Plain radiographic findings are unremarkable in the early stages of AVN, but an X-ray of the pelvis is the most appropriate initial imaging study in patients who present with hip pain. MRI shows signs of AVN well before plain film X-rays do. Conservative measures include limited weight bearing with crutches and pain medication. This may be beneficial and is a reasonable initial course of action if the involved segment is smaller than 15% and far from the weight bearing region. Bisphosphonates are only indicated for pre-collapse AVN, as their role is still controversial. Core decompression improves circulation by decreasing intramedullary pressure and preventing further ischemia and progressive joint destruction.
Nine saying he's an old fella.
he be walking with those painkillers. Now I ain't saying he's an old fella, but that hip looking kinda broke. Get down to go ahead, get down. Get down to go ahead, get down. Get down to go ahead, get down. Get down to hey. Osteoarthritis is a degenerative disease of the synovial joint that causes progressive loss of articular cartilage. Risk factors are divided into modifiable and non-modifiable, the most important being articular trauma and increasing age. As the disease progresses, the synovium thickens and subchondral bone attempts to remodel. This forms a lytic lesion with sclerotic edges. This is known as a bone cyst. Within the cartilage, changes in proteoglycans affect the integrity of the collagen. Patients with hip OA may complain of groin and anterior thigh pain initially as a deep stiffness or pain when they first get up from a seated position. After a few steps, the pain may subside in the early stages of OA, but persist in the more severe stages. Additional symptoms include stiffness with walking, difficulty putting on socks and shoes, limping, and difficulty with stair climbing. Physical examination findings often reveal a decreased range of motion, mainly affecting internal rotation and adduction. Log rolling of the hip in a supine position will typically reproduce the pain. Plain film radiography is the simplest way to diagnose OA. You should try to familiarize yourself with these X-ray findings. Treatment of OA is based on the patient's age, physical demands, comorbidities, and severity of OA. Conservative treatment for hip OA includes a generalized low-impact conditioning program, weight loss, the use of a cane to improve proprioceptive control, and NSAIDs. If NSAIDs do not provide pain relief in 4 to 6 weeks, corticosteroid injections may be administered. In severe OA and resistant cases, a hip replacement can provide excellent pain relief and improve function. In an osteotomy, either the head of the femur or the acetabulum is cut and realigned to take pressure off the hip joint. Arthroplasty replaces the damaged bone and cartilage in the acetabulum with the prosthesis.